Hello and welcome everyone to the literature review for the month of February, part 1. The first study is esmolol in septic shock. It's a two-centered, open-label, randomized trial which looked at the role of esmolol in septic shock. It was a phase 2 trial comparing esmolol to placebo in septic shock patients with tachycardia. The primary endpoint was improvement in hemodynamics as measured by the difference in norepinephrine equivalent dose within the groups at 6 hours after initiation of the study drug. The secondary outcomes were assessing the difference in inflammatory markers and oxygen consumption. So total 18 patients were enrolled in the esmolol group and 22 in the usual care group. In this, they found the patients with septic shock, the infusion of esmolol did not improve the vasopressor requirements or the time to shock reversal. However, it was associated with decreased level of CRP over 24 hours and decreased oxygen consumption. However, other inflammatory markers were not significantly decreased. So it's a hypothesis generating study, and maybe larger trials are required in esmolol or other drugs which can reduce the tachycardia in septic shock patients, which may be utilized for vasopressor requirement reduction. The next is steroid therapy and outcome of paranemonic pleural effusions, the STOP trial. Again, it was a pilot trial. The pleural effusion is commonly complicated a community acquired pneumonia, and it is associated with intense pleural inflammation. The objective of this study was to assess the effect of corticosteroids in an adult population with pneumonia-related pleural effusion. CAP patients with pleural effusion were randomized 2:1 to intravenous dexamethasone, which was given 4 mg twice daily for 48 hours, or placebo and followed up for 30 days. They included 80 patients and 51 in the dexamethasone group, 28 in the placebo group. In this, they found there was no benefit in terms of clinical parameters or inflammatory parameters by giving steroids. The next is cuff leak test and airway obstruction in mechanically ventilated ICU patients, a pilot randomized controlled trial. We frequently do cuff leak tests, so they wanted to see whether it is something which is helping us in predicting post-extubation airway obstructions. It was a multi-centered parallel group randomized trial in Canada, Saudi Arabia and Poland. Enrolled mechanically ventilated patients admitted to the intensive care unit who were deemed ready for extubation. Those allocated to the intervention arm had the results of their cuff leak test communicated to the healthcare team, who then decided to proceed with the extubation or not. However, in the control group, the cuff leak test results were not communicated, and the treating physician extubated as such. So they included 100 patients, 56 in the intervention, 44 in the control, and they found that there were 2 episodes of significant stridor in the intervention group and 4 requiring reintubation in each group. So they concluded that the result of this trial support the feasibility of a larger trial to determine the effectiveness of cuff leak tests on reintubation and clinically important stridor. The next is looking at the association of ARDS etiology and the risk of NIV failure in ARDS patients. 306 patients were included. Among patients with ARDS who used NIV as the first line of therapy were included in this trial. Pulmonary ARDS was associated with slower improvement, more NIV failure and higher 28-day mortality than extrapulmonary ARDS. The risk score combining the presence of pulmonary ARDS, presence of septic shock, age, non-pulmonary SOFA score, respiratory rate at 2 hours following NIV and PF ratio at 2 hours after NIV accurately predicted NIV failure among ARDS patients. Now, next is an exploratory analysis of association between hypercapnia and hospital mortality in septic patients who are critically ill. This was done to investigate the association of hypercapnia with hospital mortality in critically ill patients with sepsis. They analyzed 84,819 CO2 values measured in 3,153 patients, and in the analysis, after adjustment, isolated hypercapnia was not associated with the increased mortality, whereas a prolonged hypercapnic acidemia was associated with increased risk of mortality. The next is a study published in JAMA, that is the intra-arterial alteplase versus placebo following successful thrombectomy on functional outcome in patients with large vessel occlusion, acute ischemic stroke, the CHOICE trial. The study question was, does the use of adjunct intra-arterial thrombolysis following an angiographically successful thrombectomy improve the functional status of the patients in a large vessel occlusion? They included 61 males and 52 females. The mean age was 71. The study was done in Catalonia, Spain, over 7 stroke centers. Total 113 patients were analyzed, 61 in the alteplase group, 52 in the placebo group. The primary outcome was the Rankin scale. In this, they found alteplase was associated with significantly better outcome. So, among patients with large vessel occlusion, successful perfusion following thrombectomy, the use of adjunct alteplase compared to placebo resulted in greater likelihood of a better neurological outcome measured through Rankin scale at day 90. The next is hemodynamic response to crystalloid and colloid boluses during non-cardiac surgeries. This planned sub-analysis of a previous trial from 973 patients, among 480 were randomized to colloids and 493 to the crystalloids. In this, they found there was not clinically meaningful difference between the cardiac index or mean pressure variability in patients with goal-directed colloid or crystalloid infusion. Next, we come to the meta-analysis. The first is a BTE prophylaxis in critically ill. 13 RCTs, 9,000 patients. Among critically ill patients compared with control group, low molecular weight heparin reduces the incidence of DVT, whereas the unfractionated heparin and mechanical compression devices may reduce the risk of DVT. LMWH is definitively helping, but heparin or mechanical compression is not so much established. LMWH is probably more effective and should be considered as a primary pharmacological agent for thromboprophylaxis. The next is the combination therapy. Combination therapy of pharmacological and mechanical compressive devices was unclear. Sex difference in treatment of adult patients. Women are less likely than men to receive mechanical ventilatory support or renal replacement therapy, and they had a shorter ICU stay than men. There is a substantial heterogeneity and the risk of bias in literature. However, these findings persisted in spite of sensitivity analysis. This is one more meta-analysis showing that women are less likely than men to have worse outcomes in ICU. Then is the association of PEEP and lung recruitment strategy with mortality in ARDS. 18 RCTs with 4,600 patients were included. In patients with moderate to severe ARDS, higher PEEP without recruitment is associated with lower risk of death as compared to lower PEEP. However, a higher PEEP with prolonged recruitment maneuver strategy was associated with increased risk of death when compared to higher PEEP alone without recruitment maneuver. Thank you for your patience, and we will come up with the part 2 shortly.